Okay, so hi everyone, and also to those who are watching the recording back. I'm C, and I'm the Health Literacy Officer here at the Healthcare Consumers Association. I'd like to first acknowledge that we're meeting on the land of the traditional owners in the ST. That's of course the Ngunnawal and the Ngambri people. And I'd like to pay my respects to their elders past and present, and pay my respects to their continuing contributions to our culture in the region. I'd like to acknowledge any other Aboriginal and Torres Strait Islander people who might be attending today's event as well. Just for those who are here tonight, we'll just keep yourself on mute if you're not talking out loud, and pop any questions in the chat so that we can get to them. So, to introduce tonight's speaker, tonight we've got Ricky and Jason from the Walking Clinic. And Ricky has a Bachelor of Podiatry from the University of Newcastle, and he's worked alongside and learnt from his father, Richard Lee. So now he's the director and mentor podiatrist at the Walking Clinic. And his special interests include the treatment of fungal nails, including the use of laser in the treatment of plantar warts and fungal nail infections, and he finds a lot of success in the relief that laser can offer patients suffering from that condition, and finds his job really rewarding. So over to you guys. I'll let you start presenting.
Fantastic. Thank you so much for that. And yeah, look, welcome to everyone here watching tonight and the recording. So we'll jump straight into it. So obviously, thank you for that kind introduction. Again, my name's Ricky. I'm one of the podiatrists here, and this is Jason. He's also one of our team. So as said before, the Walking Clinic was started back in 1978 by my dad, Richard Lee. We've since grown to 5 locations at the moment. As you can see there, our newest clinic, Darren, is actually coming on as of the 1st of November. So we're going to be 6. But currently we've got Lyneham, Belconnen, Woden, Kingston, and Kippax, and employ more than 20 podiatrists. So we've got a fairly big team across Canberra, which has been amazing to grow and to work in. Jason actually works at our Lyneham clinic, which we are today, Woden and Kingston, and myself at Lyneham and Kingston. So what we wanted to start with today is we're going to talk a little bit about what a podiatrist does. It's probably one of the most common questions that we get most of the time. People have maybe seen a podiatrist when they're younger, or they've heard about one maybe in a nursing home, things like that. So we wanted to give a bit more clarity around what we do. It's a very broad topic. So effectively, podiatrists specialize in the diagnosis, treatment, and management of the lower limb. So this is from the hip down. Do you want to run through something?
Yeah, so some of the stuff that we do focus on, definitely biomechanical assessment. So just having a look at people's walking and running gait, try and pick up on any, I guess, abnormalities or any places that we can manage any pain symptoms as well. So we also going a bit more into biomechanical conditions, common conditions such as plantar fasciitis, which commonly known as heel pain, your Achilles tendonitis, Morton's neuroma, and your hallux abductor valgus, which will be commonly known as your bunions. We also do deal with a lot of our pediatric clientele, so our children's lower limb development, so kids with in-toeing gait or talipes, which is a club foot. Most commonly, kids will also get growing pains as well. We do also look at custom and prefabricated orthotics, but it's not limited to that as well, because we also treat skin and nail care issues. So a lot of our clientele, elderly population, or even our younger population, we deal with corns and calluses, which is the hard skin around our feet. As we touched on a little bit earlier, our fungal nail issues, so those thick yellow toenails, which can obviously cause some discomfort in shoes, as well as skin infections. Very, very commonly, we do see ingrown toenails a couple of times a day, I'll probably even say. And we also take surgical and non-surgical measures to try and manage these ingrown toenails. Plantar warts are also quite common among all our populations. Regularly see them with kids as well. Some other things that we do run in our typical consults are our neurological and vascular assessments, which would have a look at the health of our nerves and also our blood vessels, making sure that things are functioning and staying healthy in our lower limbs. We also we also work heavily to try and manage and prevent lower limb ulcerations, in particular foot ulcerations, which we commonly see with our diabetic populations as well.
Just to touch base on that one as well, Jason. So there's a huge cost of ulcerations to our healthcare system. So it's a very important area. There's more than 4,400 ulcerations a year, which is, well, even more, but they actually lead to amputations. So it's a huge thing. It's a huge cost to our government and our Medicare system. So management and prevention is a huge area in this, and that's really where things like diabetes, alcohol, stuff like that can really play a huge part. Sorry.
Yeah, and just on that final point, footwear assessment, making sure that the shoes are fitting up well. Typically we look at the length of shoes. Not often do people think about the width or the depth of shoes as well, and just making sure they've got those correct features for stability and support as well.
Yeah, 100%. We'll talk a little bit more about shoes later, but even just a simple shoe, like a simple running shoe with a toe rocker. So I've got an example up in here if anyone can see the video. That you can get these shoes from Kmart. They don't need to be specialty shoes. You don't need to go and spend $300 on a pair of shoes. But even that toe rocker can reduce ulceration risks greatly in people. So just getting the right shoes, making sure that you've got the right shoes for what you need is really important. We will touch on shoes a bit more later. So probably the biggest thing and the reason why we're all here today are basically the earliest signs of change are found in the feet. So whether or not this is diabetic related, whether or not it's age related, arthritis, any of these things, it actually is and the reason being it's the first point away from our heart. So our feet are also generally a bit of a workhorse. We stand on them, we use them all day, we take them a little bit for granted. So they're probably one of the last places that we care for. And the other thing is they are quite hard to get to in a lot of cases. So obviously reaching and checking our feet can be quite difficult. Also, another one we see is people lose sensation with their feet. So they actually get what we call peripheral neuropathy, which is where they the nerves stop working and they actually lose sensation to their feet. Another one that we get is peripheral arterial disease, which is actually where the blood flow also reduces to the feet. So the ability to heal, if you get a cut, it can be really difficult for those to heal, and that can lead to our ulcerations. Also, we spend a lot of time on them. So even us, here and I right now, Jason and I are standing up. We're just standing on our feet, all our loads going through those, all the blood flow is being drawn down there, and it's really quite hard for that blood flow to get back up our legs. So that's a really common reason we see a lot of swelling. So people get a lot of swelling of ankles. This is a really common reason as well. Just blank standing on hard surfaces can cause a lot of injuries. So they do get a lot of hard work up feet. We take them very much for granted. So there can be a lot of issues there. So that type brings us over that. Now we're going to go through some of those common conditions that we spoke about a little bit earlier. So there was, we did ask the guys at HCAA about HACC, a few questions. No, I got it wrong still. But we did ask a few questions. We wanted to see what was some common areas. One of the ones that came up quite was plantar fasciitis or heel pain or heel spurs. So I'll get Jason to elaborate a little bit on that.
So plantar fasciitis is probably, again, a common condition which we see every single day. It often starts with pain in the heel or even the arch of our foot. And this typically happens due to inflammation of what we call the plantar fascia, which Ricky will just show there.
So if you're looking at the foot, and again, this is obviously a dissected foot, but that's the point in the base of our heel back here that we see it. So this is actually where our plantar fascia here attaches onto the bone. That's the point in the heel where people feel most of the pain.
So the most common factors as to why this happens is purely just overuse. We spoke about footwear earlier, but poor footwear, people spending time in quite flat shoes or even, your real high heels. And there are obviously other biomechanical factors that do touch on plantar fasciitis as well. But to touch on heel spurs a little bit, it's something that we quite commonly see or hear about as podiatrists. And a lot of people come in and tell us that they do have heel spurs. Heel spurs don't directly correlate to plantar fasciitis. We often tell this sort of anecdote to our patients. We can grab 100 people and 40 or 60 people could have heel spurs. However, it won't be symptomatic for most people. So I guess keeping that in mind, that a heel spur doesn't necessarily correlate to plantar fasciitis, but most definitely heel pain can correlate quite commonly to plantar fasciitis.
Yeah, so big one that we see there again is, that a lot of people come in and they'll have an x-ray for other things of their foot, and they'll say, oh, they've told me on the x-ray that I've got this heel spur, do I need to treat it? No, a lot of the time, if it's not symptomatic, it's not causing the problem, you don't need to treat it at all. They're very normal adaptation that happens, that basically is just a little bit of bone growing out into that tendon, which just unfortunately happens with time and age.
Diagnosing plantar fasciitis though, again, see many of our patients come in, if they type in heel pain into Google, I will dare say plantar fasciitis will be the first thing that pops up. However, it could be other conditions. So it's usually diagnosed based on a physical examination of the foot, which is carried out by a podiatrist. We spoke about imaging. X-rays I don't tend to find are quite useful for plantar fasciitis. However, an ultrasound can probably tell us the severity of the issue. Touching onto treatment options, best thing that we can probably do plantar fasciitis and some general advice. Obviously, get it checked out if need be, but rest and modifying your activity. So lessening the load, lessening the amount of time that we spend on our feet, so that those pain symptoms can come down. Medications such as what we see there, which are our NSAIDs, which is basically your Nurofen. So an anti-inflammatory medication can really help. Yep.
Always be careful if you are taking a Nurofen though.
Absolutely.
Make sure you take food. If you are on any other medications, check with your pharmacist before you start taking anything like that, because unfortunately NSAIDs or Nurofen and things can cause stomach upset. They can cause other reactions with medication. So you do want to be careful with that. The other thing I was going to jump back to, is this is a very common condition. 10% of the population get this. So in all of us, it's really readily out there. We see a lot of it. It's something probably, like we said with the other things, we treat daily. We see in that clinic on a daily basis someone coming in with plantar fasciitis. So it is very common and it's very debilitating, and it does have a lot of range of severity. But we'll go through about 2 more.
And just touching on your anti-inflammatories, again, if you are ever unsure if you're able to take something like Nurofen, typically an anti-inflammatory cream can work quite well as well, and it targets that area quite well. But again, always check with your pharmacist or your healthcare professional as well.
Not a plug for this or anything like that, but physio cream is one that we use quite a lot. Again, these are products that we personally use, but this is actually a natural product, so it doesn't use the harmful things like that are in Nurofen or ibuprofen. So this uses arnica and bits and pieces like that. So if you do have any other reactions to other creams, this one can be quite a good one as an anti-inflammatory cream.
Also, other things to look at. Typically, your stretching and your strengthening of the areas. A lot of the time, it comes from quite a tight calf muscle as well. So focusing on stretching and strengthening the calf muscle. And then other things come into play, such as our athletic devices and also supportive shoes. Yeah. In our real severe cases, sometimes we might offload the area, or sometimes a cortisone injection might be used, or even a surgical intervention if it is something like a severe tear.
A big one I use for my patients is just a simple stretch out of bed. So imagine, this is your foot, as you're sitting there in bed, just bringing your toes back towards yourself, not really stretching on it, but just by bringing your toes back towards yourself and putting that stretch on before getting out of bed. That's probably one of the most common symptoms we hear as well. People feel like those first few steps out of bed, they're really limping and really struggling. So just by warming up and having a light stretch on the foot can make those first few steps a lot better. Other thing is ice and heat as well. Yeah. Ice is an anti-inflammatory effect. So if you get a water bottle, a standard sort of water bottle like this, fill it with water, obviously, freeze it, and then use that as an ice roller underneath your foot can really help with that. Transversely, also heat can be quite good because it actually, I do a bit of a contrast. So I do generally 5 minutes on an ice bottle, rolling your foot on top of that. Then I'll actually get people to go and put their foot on a wheat bag or a heat pack for 5 minutes, back to the ice for another 5 minutes, and then back to the heat pack for 5 minutes. So it's 20 minutes total, it's alternating. The ice reduces inflammation, the heat actually increases blood flow, which increases healing. So it's this spasm effect that can really help the symptoms as well. Cool. Awesome. So the next one, now just to give you this, so we've got Achilles tendonitis here, or Achilles tendonitis. Basically, any of these sort of things, the itis on the end of them is inflammation, so it's actually swelling. If you see osis, it's inflamed without actually swelling, so it doesn't increase the size, but that's another thing. So any word that has those at the end of it basically means it's angry. There's something going on there. So that's always just a little fun tip. This one again.
Yeah. So again, we're looking at Achilles tendonitis. So plantar fasciitis was over there at the bottom of the foot, whereas your Achilles tendonitis tends to affect that back calf region and down into the heel where it connects. So again, it's just an inflammation or sometimes a degeneration of the actual Achilles tendon, which can reduce in a bit of pain and reduce mobility. Again, getting out of bed first thing in the morning or sitting down for long periods of time and getting back up again, people will feel that stretch and that pull in their Achilles. So what exactly is that Achilles? As we explained, it's actually a large band or a tendon that connects up into the calf or connects the calf muscle down into that heel bone. So quite similar to plantar fasciitis, commonly caused by overuse, improper footwear, or a sudden increase in physical activity. We see this with people who take quite a long break from running, for instance, and then decide after several months of not running, they're going to go do a 5 or a 10K run. It really just makes that Achilles a little bit angry.
Just for a fun thing. These are not exclusive just to you guys as well. I got myself Achilles tendonitis, a bit of inflammation the other day. I increased my running too quickly. So I've had to rehab myself and go through this process. So it's not, we're not immune from this either.
Do you have some tips on easing back into exercise after, say, a long period of illness or taking a break like that?
100%. Yeah. So easing back into exercise is a really important thing. The best rule that we use is the rule of 10%. So the rule of 10% basically means you can't increase your load more than 10% in 1 week. So you need to start easy. Obviously, you need to start somewhere. It might be a few hundred meters, but the biggest increase we see is if people try and increase that curve too quickly. So they'll go from, say, like a kilometer walk to a 5-kilometer walk. That increases too fast. Basically, you've got to do it incrementally. 10% at that stage can be very low because effectively you're doing a 1 kilometer walk. That's only 100 meters extra. So you're doing 1.1. And then the following weeks, a little bit more. But again, it's a very slow, gradual sort of trend, but that's the best way to increase it. It's not to overdo it. People, I know myself, I did it. You get the urge to keep going and want to go harder. It's basically a very steep curve. If you go more than about 40%, your likelihood of injury is huge. It's huge. So that's one of the real big tips that we use. Starting lightly, even starting into, if you really haven't done walking or running or anything like that in a long time, starting in a treadmill or starting on a cross trainer machine, reduce impact. Even getting in a pool, doing some running in a pool, reducing that load can make a huge difference. Other thing there is strength training before you go into those activities as well. So seeing, we've got ourselves or, exercise physiologists to work on a strength program to actually allow your body to be strong to do the activities is really important. But, yeah.
I won't repeat myself too much because you have a look there, the diagnosis and the treatment option, quite similar to plantar fasciitis. As I said, it's quite a similar condition. One is just on that plantar surface of the foot, one is a little bit higher up. So with that diagnosis, again, a physical examination carried out by a podiatrist can typically diagnose that issue. Sometimes imaging such as ultrasounds or MRIs can just be used to assess the severity. Treatment options, again, quite similar to your plantar fasciitis there. Your rest, your activity modification, your stretching and strengthening, and orthotics and supportive shoes definitely help there.
Big one for that is actually loading it. So we actually want to, it sounds counterintuitive, but you actually want to load tendons. But you have to do this, again, this is where it's really good. See a physio, see a podiatrist, see someone about it because they'll give you the right loading programs to make sure that you actually get the tendons stronger. So tendons don't always just need a whole bunch of rest. Initially, obviously, if it's inflamed and you've irritated it, rest is best. But then also, once you start to get into that process, you need to actually load the tendon to allow it to heal. So that's a really important one as well. And it's doing that safely. So yeah, we're going to arthritis. Arthritis is a very general, broad term as we've got up there. Yeah, cool.
All
so
right.
yeah, you go.
So arthritis. So basically, as Ricky said earlier, the itises there, they tend to refer to inflammation. So now we're not talking about tendons, we're talking about the joints. So arthritis causes that inflammation of the joints, which will cause that pain, which will cause that stiffness, that swelling, and then overall you get that reduced function. So what can it be from? It can either be due to wear and tear of the actual joint. We tend to see that quite commonly as we do get older, or in other cases of arthritis, it's more of an autoimmune response, sort of the body attacking itself in a sense.
Yeah.
So your most common type of arthritis that you'd see, definitely your osteoarthritis, which is the wear and tear, your rheumatoid arthritis, which is more autoimmune, and your gout, which I guess is sometimes lifestyle modifications to try and treat that one.
Yeah, so to give you a bit more clarity on the osteoarthritis here, like Justin said, it's our wear and tear sort of one. So it's basically anytime we use anything, it wears. It gets, things happen. Our knees, hips, they're the most common type of arthritis that we see that cause people to have hip knee replacements. As you can see across our foot as well, there are a lot of joints in our foot. So there's a lot of bones in here. There's a lot of different movements. And so arthritis is very common in the feet because of all these joints across here that have to move and keep moving every time your foot moves. So it's very, very common. It's something we see a lot of. Again, osteoarthritis is probably our main arthritis. Rheumatoid arthritis, again, people will be diagnosed. It's an autoimmune condition. It will affect joints all over their body. An autoimmune condition is actually, the body attacking itself. So our immune system starts actually overworking and attacking our joints. So generally people are on medication. Gout, as Jason said as well, lifestyle. It's actually we ingest too much purines, which is products in our food, or all that sort of stuff, which actually then causes gout, uric acid to build up in our joints and causes them to become red, hot, swollen, really irritated. But yeah, we'll go through some more.
So how is this typically diagnosed? Typically, these can be diagnosed by a health practitioner, but it has a lot of, a lot to do with our general practitioner. So it involves, a medical or family history of particular arthritis. Also, a review and physical examination of the swollen joints and where the pain is also happening, and also the overall range of motion of the joint. So we tend to see reduced range of motion in the joints when we have issues such as osteoarthritis. Furthermore to that, again, imaging such as X-rays or MRIs can evaluate the joint damage. For our more autoimmune conditions like the rheumatoid arthritis, we sometimes need to carry out blood tests which will identify high inflammatory markers in our blood, and that can help aid in diagnosing the specific type of arthritis. Onto treatment options, a little bit more broadly, which is not what a podiatrist deals with, but more so the management of a GP or a rheumatologist. They will look at different types of pain medications, starting from something as simple as your anti-inflammatories such as Nurofen, but can go on to something
Panadol osteo, is another big one that we see a lot of patients on.
Panadol osteo is definitely one. But also when we start to get into our more autoimmune conditions, it's more often disease-modifying drugs or even biologic therapies, which, as I said, will be prescribed by a GP or a rheumatologist. But the huge thing for arthritis is definitely physical therapy. So we often say, you need that movement to create lubrication in the joints. So the more we sort of move in the correct manner, the better those joints will start to move, and the range can sometimes increase as well, which is when we look at something like the GLAD program, which Ricky will probably elaborate on.
Yeah, so the GLAD program is one that's actually not done by us as podiatrists. It's done by physiotherapists, exercise physiologists, but it's a fantastic program. It's actually a program called Good Life with Arthritis. The D is actually Denmark. So it's actually a program that's developed in Denmark to treat arthritis. The literature behind it actually showed a 50% reduction in hip and knee replacements when people do this program. So it is really, the evidence is showing really, really strong stuff. So we actually have physios and exercise physiologists that actually work with us. We've got the Canberra Physio Clinic as well. They provide the GLIDE program as part of that. But it's an awesome program for anyone that's suffering those arthritis. The other arthritis that we see, so this is really, really good for hip and knee exercises and stuff like that. The most common ones that we probably see as podiatrists are what we call midfoot arthritis, which is midfoot is this point across the foot in here, which is where people get sort of pain on top of their foot. It can be from footwear coming down onto it, or it can be actually impingement. What happens with those joints is as the foot comes down, they actually jam at the top and close, and that can cause wear there, and that can cause pain across the midfoot. The other place we see it is the big toe joint. So this joint here, bunions, it's probably our most common joint that gets wear. It can deviate and really cause some pain. So those two areas are something as podiatrists we really work on. We work with orthotics devices, doing all these other bits and pieces, exercise, footwear. So again, I sort of come back to my shoes with toe rocker. A lot more shoes now are getting a lot firmer in the toes with a lot more rocker through it. That's actually really beneficial for anyone that has big toe pain or fourth midfoot pain to allow that to rock. But that's a really big thing for us as podiatrists. We'll help manage those bits and pieces and help the symptoms and manage it the best we possibly can. Arthritis is one of those hard things. Again, you can't fix it apart from having replacements. But it's management, yeah.
Just touching on a little bit more about the arthritis there. So even though we do see arthritis a lot more in the foot as podiatrists, there are other arthritises that we do see typically our patients come in, which affects their hands, their backs, their hips, and their knees, which actually draws some of our patients in because getting down to your feet or something as what we would see as simple as clipping our toenails becomes quite hard when you don't have that range in your hand. So, arthritis unfortunately can riddle any part of your body. So the role of podiatrist stems more than just the typical foot arthritis.
Yeah, certainly. General care, general assistance with that sort of stuff is something we do a lot of as well. So there's a lot of aspects. So again, another question was around lymphedema as well. And so I wanted to touch base a little bit on lymphedema and sort of educate a little bit more around what that is and how we can sort of manage it as well.
So lymphedema, unfortunately, this just causes swelling to any part of the body, but typically affects the limbs. So this is why we see it quite often with podiatrists, because we see it happen in the legs. So how does this happen? It's usually damage or obstruction of the lymph nodes or the lymph vessels. So usually as a result of something like surgery or cancer radiation therapy. Some infections can also cause the lymphatic system to be compromised, and also some congenital conditions which we're actually born with.
So just to give a little bit more clarity around that as well, there's two types of swelling that we see. We see venous swelling, which is actually the veins, and people get varicose veins and their legs, basically the veins can't get enough blood flow up. This is the other type we see is lymphedema. Lymphedema is actually what happens when our blood comes down the leg. The blood goes out to the vessels. It then creates the fluid between our cells is actually lymphatic fluid. That lymphatic fluid actually builds up in the legs and causes that. Like I said, it's meant to drain through our lymph nodes and our lymph glands, which are basically all over our leg and come up into our groin. But again, if they get damaged or have an issue with it, then they can cause this lymphatic fluid not to drain out of there, and it causes this amount of swelling. So there's two types of main swelling we see, which is venous swelling, which again is generally people get from standing for long periods of time. Their legs will be down in the morning but blow up through the day. Generally, venous swelling lymphedema. The swelling is generally there more long-standing. It's generally firmer and stuff like that. So there are two types of differentiating which one people have. But yeah.
But that being said, more than likely this condition is typically picked up quite often by your GP, or after something like a surgery or radiation therapy, they would have picked up on these issues, and the patient would have probably been educated around it. But sometimes it can go a little bit missed, and the podiatrist can pick up on this. So diagnosis, again, usually through medical history, physical examination. They measure the limbs or the affected limb and measure it obviously to the opposite side as well. And there is what they call lymphatic function assessment as well, but again, more so carried out by GPs, I believe that one. So your main treatment options, essentially, we want to look at reducing swelling and try and improve function, overall function. So one more common one that we see a lot of our patients get is actually what they call lymphatic drainage, which is sort of a massage and using manual therapy to try and drain that lymph fluid that builds up in there. Compression garments or compression stockings is something that we see quite often. It's really important that if we are going to get into something like compression stocking or compression garments, we need to ensure that we actually have nice, healthy blood flow down to those limbs as well, because we don't want to add extra compression, which will restrict the blood flow. But essentially, compression can actually help with that sort of mechanical pushing of the fluid up the leg as well. Exercise, keeping up with exercise, again, using that mechanical power to try and push the fluid up a little bit. In some cases, sometimes standing up for a long period of time can increase the swelling, but exercise can help reduce that swelling. There was a question as well about skincare in regards to lymphedema as well. It's really important that we do take care of our skin when we do have an issue like lymphedema, because the area can get quite swollen, and when it does happen, it actually makes the skin quite fragile. And when we do get quite fragile skin, tears can occur or little punctures in the skin can occur, which then can lead to something like infections or cellulitis of the actual skin.
Yeah.
So keeping the area nice and moisturized and nice and healthy is really important when we do suffer from something like lymphedema.
Anyone like venous swelling or lymphedema, they basically are at a higher risk of infections and those skin changes. So it is something that really needs to be managed well. Generally, with lymphedema, and venous edema as well, we see the skin really dry out and change its quality because that fluid. So both lymphatic fluid and venous blood flow are both actually waste products our body is trying to move away from the area. So it's actually it's the products that have done their job. They're meant to be going back to our liver and be excreted and moved out of there. So they're actually not products that we want sitting there for long periods of time. So it does cause our skin to change, and it does cause it to deteriorate and become a higher risk of infection. So it is really important. That's probably where podiatry comes in the most, is managing the skin, managing infection risk, managing people with nail issues. A lot of times, due to the swelling, they can get a lot of compression between toes and have high risk of infection in between the toes. And then also footwear can become really difficult because obviously the size difference and the swelling of limbs. So a lot of the time, there are footwear options which allow for this. They're not always the prettiest. They're not your nice shoes, but like lymphatic shoes, which actually have a lot of stretch in them and allow for that swelling to move and be allowed, and then straps that really adjust and open up. So this is a brand called ProPay. They make a really nice one. Dr. Comfort make another one as well, which is again elastic sort of neoprene upper that allows stretch and movement as we swell, because these legs will go up and down through the day and they can change, and so it's really important. Skincare, it's to be honest, we sell fancy moisturizers, but moisturizer is not. It's much more about routine. So you can get the best cream in the world, if you're not using it, it's useless. So it's about making sure that you're getting into a good routine, particularly with lymphedema or venous edema. I'd say almost twice a day you need to be applying moisturizer to the lower legs. Avoid in between our toes because there's already too much moisture in between there because it's quite tight. But you want to get underneath the feet and up the legs really even twice a day, morning and night if you can. Cool. All right. So one thing obviously we did want to jump on is when to see a podiatrist. Obviously, there are lots of bits and pieces you can do. If anyone is suffering a chronic condition, you can get rebates to see a podiatrist. So there's basically a couple of options. Obviously, we're both private podiatrists. We work in private clinics. There are also ACT Health podiatrists as well. So ACT Health have in their community sort of setting, they have podiatrists there. They also have a high risk foot team for anyone who is suffering ulcers and stuff. You'll be referred into that. So if you obviously can't access a podiatrist, don't have the money to do it, there are government podiatrists who you can see. Obviously, they'll assess your risk and sort of deem if you're eligible or not. They'll definitely look after you for that consult and say, no, sorry, you're not eligible for our service, or they'll take you in. But certainly you can get on contact with ACT Health and see a community podiatrist. Obviously for us, there are options as well. We are Medicare. We are with Medicare if you have what you call a team care arrangement, which a lot of people may have through their GP. It's basically anyone suffering from a chronic condition like lymphedema, diabetes, rheumatoid arthritis, different bits and pieces along those lines. Those chronic conditions make you eligible to get a subsidy for podiatry. So it doesn't pay a whole lot, but it does pay, I believe, $56, $58 of your consult towards it. So there may be a gap fee depending on who you see. You don't require a referral to a podiatrist, so you can just call up and book an appointment with anyone. But obviously, to get that subsidy, you do need to see a GP and get a referral if you're eligible. Your GP will say, yeah, look, you're eligible for it or you're not. Obviously, most podiatrists also accept private health insurance. So if you have podiatry cover on your private health, you can see a podiatrist for sure. It is recommended that, that particularly anyone living with diabetes is basically seen by a podiatrist every year. And we go through an assessment to see how their blood flow and neurological status is going. That's recommended by Diabetes Australia and the Australian Podiatry Association. So we are going through some more stuff to what to look out for at home. So a big one that we commonly see, and I spoke about, and obviously I've sort of done a bit more work on, is fungal nail infections or tinea infections. Tinea is actually when it's on your skin, and most people have heard of tinea in athlete's foot. These fungal infections are something that live around us every day. So they basically live on our skin. They're like bacteria. They're just a fungal infection. Once they get onto our skin or into our nail, they actually live off what our skin and nail are made of, which is keratin. So they actually, it sounds gross, but they eat it. And it feeds them. So as you can see in that picture, you can see that nail is discolored, it's brittle, and it's really thickened. That's a common fungal infection that we see, and that's where it basically gets into the nail and actually causes degeneration. Interestingly enough, they actually live really, really well in there. They're actually really quite hard to kill. And it's because that they basically have nothing irritates in there. They've got their own supply of food. They do all things, and they can really come through it. They can spread to other nails. So that's a fungal nail infection of the nail, but also you can obviously get tinea on the skin, which causes that sort of red rings, itching, little spots across the foot as well. There's three options of treatment when it comes to any of these sort of things. As I said earlier, we do laser treatment, which is a sort of newer technology that's now used by podiatrists to treat the nail infection. It basically is probably the biggest advancement in this sort of area that we've had in probably the last 20 years. It's still not 100% successful, but it is much better than some of the other treatments. But it basically uses heat to destroy the cells inside the nail and get them to grow out. The other option, obviously, is topical treatment. So you can get nail paints and tinctures, they call them, which can go onto the nail. You can get from the chemist to trial. They're certainly a good place to start. They require a lot of persistence and a lot of dedication from the patient. You basically have to apply them religiously till the nail grows out completely. So you're looking at up to 12 months of treating it on religiously to try and get those to work. The literature doesn't show great success rate, but there's certainly a good place to start before going other ones. Third one is oral medication that you can get from your GP. This is the most successful treatment, but unfortunately it also has the most side effects. So it can lead to liver and kidney damage. But again, that will be discussed with your doctor, and you can go through and work out whether or not the prescription's right for you and go through there. So generally what they'll take is they'll take a clipping of the nail, they'll send those away to pathology to test the infection, and then if it comes back with the infection, they'll put you on the medication. The thing is that you're generally on a tablet for 3 to 6 months to get this to grow out and do it. And so they'll monitor your liver and kidney function while you're on it.
So other things that we commonly see are definitely your hard skin or cracked skin. So what we refer to as calluses and fissures. which for some people may not seem like a big deal, but a lot of the times getting one of those cracks in your skin can be extremely painful. And it's not primarily the pain that we're overly concerned about. It's actually the portal of infection, the portal of entry for infection that we get really concerned about. Some people can withstand the pain, but an infection is obviously much more detrimental to our health. So the management of that is really comes down to regular moisturizing, like we spoke about with lymphedema. It needs to be a regular routine. When they're as severe as what we see in that picture there, it's obviously quite important to get that skin pared back, which is something that we do as podiatrists here. We debride the skin using the scalpel. We make sure that we get that skin back to a bit more of a smoother, a smoother skin. get it back nice and smooth, so that you can then start your journey of moisturizing it and getting it back to where it needs to be.
So you think there, guys, well, that isn't painful. Everyone's scared. As soon as you say you're using a scalpel to someone's foot, we're removing dead skin.
Yeah.
So it's actually not, skin you feel. If it's done correctly, you won't feel a thing.
Yeah.
It's completely painless. It's very easy. It's a management that we do daily. And again, I've had a lot of people come in and I pull out a scalpel and they're like, "Oh, what are you going to do?" But no, we're just debriding that dead hard skin that's creating those fissures and cracking around there. So it should be quite painless.
But we definitely see this coming up into our warmer weather as well. So coming to summertime,
Sandals are bad.
People like to spend their time in sandals, Birkenstocks, and all of those sorts of things. The moisture gets drawn out of our feet when we have open back shoes, I guess, and that's what can cause that dryness to initially start, and that dryness then leads to the hard skin, which then can lead to the cracked skin left untreated.
So one I like to use as well is actually, if you get a really bad one and it's getting quite painful, actually applying a dressing to it overnight. Using a dressing that sort of you can put over the area, and actually using pawpaw ointment. So pawpaw ointment I find quite good. It's very good at healing. Obviously, if you have an allergy to pawpaw, don't use pawpaw. But it's a very natural product. It's very thick, being sort of that Vaseline sort of consistency. It absorbs in really well overnight and helps really soften the skin well. It also helps healing. So if they are bleeding and sore, basically what I get patients to do is apply some pawpaw ointment to the area, put a dressing over the top of it, and then maybe put a sock on and wear that night. And that can be a routine people can do for a few days until that sort of soft skin skin softens. Then using a pumice stone and regular moisturizer can be helpful. But obviously, if they are painful and stuff, as Jason said, coming and seeing a podiatrist, again, any podiatrist, it's sort of not exclusive here. If you see a podiatrist, it's great. And so, getting that skin debrided back so that you can start from scratch, and then we can work on that process of keeping it down.
And touching on cuts and grazes, it's obviously not something we expect everyone to run off to the GP or their podiatrist to, as long as we keep it clean once we get those cuts and grazes. So we tend to tell people to clean the area with some saline and then apply a dressing, obviously allergy dependent. Betadine works quite well as a bit of an antiseptic, just to clean that area. Reason why we get concerned again with cuts and grazes is anything that opens up the skin is just a portal of entry for infection to happen.
Yeah, particularly we get a lot of people that walk around barefoot outside or something like that in the garden. Obviously, bacteria loves dirt. So if anyone's doing that and you get a cut or something punches your foot and you get an infection in there, it can cause a really bad time. So we want to try and avoid that. Also, saline, if anyone doesn't know, it's salt water. So you can actually make saline yourself. It's literally like boiled water and generally we'll say a litre of boiled water, 2 teaspoons of sea salt, but just salt dissolved in the water and flush it out with that. That will help. But then obviously antiseptics as well.
But wait for the water to cool down.
Yeah, don't use boiling water. So that's a bad time. Don't cause yourself burns. There is worse.
We'll touch on this a little bit later, but we speak about infection quite a lot. So for anyone who's not familiar, when you're thinking of something like infection, if the area becomes red, hot, swollen, if there's pus oozing out of the area, that's what we refer to as a localized infection. Your systemic infections include, your temperature rising, feeling nauseous, cold sweats. any of those sorts of things require pretty much urgent medical attention. Okay.
Yeah, seek hospital. Don't. Yeah, just go straight to emergency.
Yeah.
Cool. Ingrown toenails. This is probably something we see a lot. Heaps again. We see a lot. All these things a lot. That's why we're putting it in. But this is one we see a lot. Again, probably actually the most common age group I see is probably teenage boys. I don't think we have too many probably in our talk today, but they're the most common group we see for ingrown toenails. Basically, they tend not to worry about themselves. They tend to squeeze themselves into football boots or go kick balls. They also tend to pull their nails off. We don't want to do that. That's a bad time. And obviously, you can see this side of this toe is very inflamed. And as Jason was just saying, you can start to see what we call erythema and that redness. That's actually infected on the side there. So you can see that redness starting to move down the foot. That's actually infection. So that's starting to get infected, and it's starting to cause a fair bit of irritation there. And you can see the tissue right on, which is really red and so irritated. That's called granulation tissue, which is really highly vascular and really painful and bleeds really, really easily. So if you touch that, it bleeds a lot. So it's really irritated and angry tissue. So the best thing you can do is it's generally down in proper nail cutting. So generally people try and cut their nails down the side, and that causes the nail to stay down in the tissue. And generally what happens is a little bit breaks off and it starts going up the side into our skin. So they are really, really painful. We clear them up. We do both surgical options and non-surgical options, so we can clean them up in the clinic. Obviously, it requires us to go down there with a scalpel. It's generally 90% is pain-free. But again, they are irritated, they are sore, so we've got to get it cleared out. The other option, obviously, we actually do a nail procedure called partial nail avulsion, where we actually give a local anesthetic to both sides of the toe, so you get it numb, and then we actually cut that whole sort of nail out. We're only cutting nail, we're not cutting the skin. It's just removing that piece of nail that is in the tissue that's affecting. Things to do at home, though. So reduce the pressure, obviously. It's generally likely that it's from pressure of footwear or something's compressing onto the toe that's causing that irritation. Again, soaking in saline, so making some saline water, soaking that helps flush out any of that bacteria, any of that irritation. Applying antibacterial creams or liquid like betadine, keeping it dressed, and then obviously seeking a podiatrist. A lot of people, again, go to your GP, you can get some antibiotics. That will help settle the inflammation down. It won't actually treat the ingrown toenail though. So we get people who go on repetitive courses of antibiotics to try and fix it. It doesn't fix it, it just manages the infection. So we actually have to get that bit of nail out to manage the infection, to get it to go away. So that's where that combination can really help. So it's digital maceration. This is one we spoke about a little bit with lymphedema earlier. So when the toes are close together and we get moisture in between our toes, it actually causes breakdown. Again, this all sort of comes back to infection risk. So that breakdown of that white tissue is actually dead skin. It attracts bacteria. Bacteria then leads to infection. It then leads to issues. So again, we don't want that tissue there to be that white, pruny tissue. It means moisture sitting there. Easiest way to fix that is drying between toes. So if you are getting maceration, if your toes are very tight, you need to dry in between there. A couple of good ways that we do that, or we advise people to do that. A ruler with a small little bit of towel on it can actually help if you can't get down there. I mean, the simplest way, obviously, is get your foot up and just dry between your toes, but that can be quite difficult. So using a towel with a ruler with a small piece of towel around it just to help get in there. You can buy specific things for it, like Mobility Matters, stuff like that actually have things that are like a ruler, a stick with towel on the end of it you can actually use, but it's a bit excessive. So the other thing is alcohol wipes as well. So alcohol draws the moisture away and it dries really well. So it sounds a bit old school. My dad used to recommend a lot of methylated spirits. So like using methylated spirits mixed with a bit of water. So generally a 70-30 mix, 70% methylated spirits, 30% water. And in a spray bottle, spraying that between the toes as well. I didn't put it on there because it's easy a little bit old school.
Ricky,
Yes.
I've heard some people like to use things like talcum powder in their shoes to manage this. Is there any issue with doing that?
Yeah, so talcum powder is good. The one problem with talcum powder, it absorbs moisture, but it also actually it turns gloggy, so it actually doesn't absorb that much moisture. And so it sits there. Yeah, it sort of sits there. It becomes almost like a paste-like if it gets moisture. So if there's too much moisture in there, talcum powder really does clog up and create issues. It also turns everything white. So you know white feet everywhere. But talcum powder, if there's a low amount of moisture, it's quite good. But generally, we say something like alcohol, it dries off the skin a lot quicker. So it's actually just going to evaporate off a lot quicker and dry it out. The other thing is moisture wicking socks. So that's another thing. So using natural fabrics, like I would generally recommend cotton, natural moisture wicking sort of fabrics will absorb moisture. You can get fancy products like that have cool max and moisture wicking products in the socks. I don't know how effective. I mean, they're a bit tricky, but yeah, cotton bamboo. Bamboo is another really good one as well. Helps absorb moisture. Those sort of things. You can even. I had a little cream as well that we had here as well, which is actually this one's called Acrylamide. But you can actually get antiperspirant creams as well. You don't want to use these so much between your toes, but if you do have a big issue with sweating, and some people really have, it's called hyperhidrosis. We get a lot of sweaty feet. These creams can really help with that as well. So you go to the chemist, getting a cream that helps the excess moisture will help reduce that. But yeah, look, talcum powder is fine. It's just you got to be careful if there is too much moisture. It will turn a bit pasty and a bit thick. Cool.
Touched again on this with hard skin, but corns and calluses. So areas of hard skin or places that are quite prone to friction. So the pressure and the friction onto those areas can actually cause irritation, which can then cause issues like blisters and calluses. Now, why do we harp on so much about calluses? You have yourself quite a thick layer of hard skin pressing up into softer skin, which can actually then break down that soft skin and cause issues like an ulcer, which you may not even see because it'll be protected or covered up underneath a thick piece of callus there. So it is quite important that those calluses get debrided down quite regularly, so that you don't have an ulcer that goes unmissed.
Yeah, it's a really common thing that, again, so it's common, but it is a common thing we see. We'll be debriding. We'll have someone come in with a large callus, and we'll actually debride the callus and remove it, and then find actually there's a wound underneath it, and so that can be a real problem. We've got to offload it and keep the pressure away from it, but they are things that basically can hide things. So that's the biggest thing we need to make sure. Now, again, it's not going at yourself and bringing out the old Stanley knife and cutting them off, because that will cause more havoc. So don't do that. But things like pumice stones, moisturizing creams and stuff can help keep them down. But obviously, prevention is best thing. Reducing why we're getting that pressure there, that friction, making sure your footwear is appropriate. Temporary offloading if we need to, so that we can look at things like little toe props or doing some padding inside shoes to offload the area, and then obviously other bits and pieces to help manage it and remove it. So they're another big one. But again, we get a lot of people with corns and calluses. Corns can cause a lot of pain. It feels like people are walking around on a stone. It's actually a hard little diffuse point of hard callus inside your foot, and they're like a core that go in, and they can be really, really painful. So a lot of people get them under the ball of their foot, then get them on toes, in between toes, interdigital corns. So they happen in between like a little, we call it fourth and fifth toe, but in between little toes, the pressure in between here can cause friction, and that can cause corn. They can get quite bad. So there's lots of different bits and pieces that we can see on there. All right, this goes into more fun. This comes back to our venous pooling. These are some pretty looking legs. Effectively, venous pooling again brings us back to that lymphedema and venous edema. So this is actually when the blood flow goes down to our legs. So it's very good at getting down because obviously it goes through our bloodstream. It gets the heart's pumping down and it gets down there. And gravity is also helping this a lot because while I'm standing right now, gravity is drawing blood down to my legs. The problem in this case is the blood getting out. So our veins stop working as well. Arteries are very different. So arteries are basically very elastic sort of thing. And so they have a lot of force. When the blood goes through them, they sort of bounce and keep well. Veins are not. They're very floppy and very open. So they distend a lot and they become bigger very easily. And that's where people get varicose veins, spider veins, things like that. And that distension causes the ankles to swell. And then that swelling actually causes the blood to pool in that area. So that's what actually causes that, that discoloration. Is like I spoke about before, the blood pools in the area and the bad products like the iron and all the things that are trying to get away from there actually leak out into the skin. And so it causes this staining. It's called hemosiderin. It causes that staining of the skin. The skin becomes very thick, very hard, and it's very high risk of breaking down. You can see some ulcers and stuff like that on those legs. It's a high risk of breaking down. So what do we need to do about those? Movement. Movement actually helps. We have what we call muscle pumps. When we exercise and move our legs, the muscles actually can contract the veins and cause the blood to move up, and also elevation. Obviously, getting the fluid out. That's why people in the morning they wake up, their legs are quite down. There's not much swelling. Through the day, they start to swell through the day. So keeping that elevation, keeping those exercises, keeping that movement happening will help reduce it. Then obviously compression stockings as well and other bits and pieces.
Keeping on to what Ricky said there about the veins, they have valves in them that actually help push the blood back up, and those valves start to get a bit weak over time, and that's what will cause that swelling to happen, which is why that movement or activating that calf muscle pump is really important, because it can help act like the valves to push that blood back up.
Yeah, and so this really only happens actually in our legs, and it's around this lower leg that it most commonly happens. Doesn't really happen. We don't see it in our arms. We don't see it in those bits and pieces because we're moving them so much. So it's a really consistent thing. So elevation, exercise, and compression are your best things.
Gravity doesn't really help, which is why we tell people to elevate their feet.
Yeah, this is the other one. So this is what brings us back to where we were talking about earlier. Why we want you to worry about all those things is basically because of this cellulitis. So as you can see, there's quite a difference between these two legs. You can see the left leg is very swollen and very red. And that's actually an infection of the skin. So cellulitis brings us back to that same thing with the itis on the end of it. So it's inflammation. It's actually inflammation of our skin or our cells in our skin. And this is actually quite severe. So if you end up with your feet like this, you need to go to hospital pretty quickly because it's actually quite a severe infection. They'll actually monitor it and see if it's tracking further. They'll generally put you straight on IV antibiotics and you'll be in hospital. So this is the big one to watch out for. And this is the reason why we say or worry about all those things, because quite commonly we see a small cut, a scratch, a fungal nail, something like that can lead to these sort of things. And we don't see it commonly, but I've had a few patients that have come in and I've sort of said, what's going on with your legs? And they're like, oh yeah, I've noticed my leg gets swollen. Yeah, I'm like, yeah, okay. So we're sending you off to hospital now. And so that happens in our clinic as well. It's something we obviously can't manage. We can't put an IV antibiotics and sort of manage it, but it's one of those sort of strong ones. So again, that's something to look out for. I don't think everyone should see it, but
quite painful as well. So a lot of times people would have already sought some medical attention about it because of how painful it can become. But if you haven't, as I said, the big three things is red hot swollen. Seek immediate medical attention for that.
Yeah. The big thing as well is difference between your limbs. If you start noticing one leg doing something different to the other, that's sort of a red flag. Get it checked. Get it checked by the GP. Obviously, the GP can manage this. You don't need to see a podiatrist, but again, we'll be sending you off to hospital. But you certainly have some advice if you need to. So we'll go other things you can do. So obviously, the big stuff that we see is socks. And so we touched a little bit about on before, and cotton socks and different bits and pieces. You don't need to spend heaps of money on socks. Socks are a real thing that, you can spend $30, $40, $50, maybe not 50, but at least good money, $30 on a pair of socks quite easily. They're sometimes more comfortable. They have some more cushion in them, stuff like that. But you certainly don't need to go and spend a lot of money to get good socks. So these are two sort of brands that we sort of use quite a lot. All day socks, you get them from Woolworths, BW, Coles, stuff like that. They're a comfortable sock. They're generally got good moisture wicking, and they generally have fairly good cotton products in them. They do have some synthetics. They got a little polyester and elastin, but again, they are majority sort of cotton and stuff like that. So again, they're sort of an easy sock. The other thing you sort of want to look for is fairly loose tops. So you don't want to. You can sort of see this one does have a seam around the top of it. We generally don't like that too much with our people that have swelling or diabetes, because it does sort of create a tourniquet effect. What some people do, obviously, is they can just cut that area and loosen that off so it doesn't. You want to have this more graded sort of product all the way through it. That makes a big difference to the socks to do it. But again, probably the main thing there is you don't have to spend a huge amount of money on socks. Just make sure you look for those basic things. Try and get something that's not going to stretch onto your. So these come little 3 packs. Sorry, I actually grab one out. But again, it sort of just comes out and a bit more stretchy around the top. It's not going to tourniquet your leg and cause too much compression. Again, they're pretty easy. Natural fibers, moisture wicking, and make sure it's not compressive. If you notice that after a day of wearing your socks, you've got a ring around your leg that's cut in, they're too tight. You need to cut more. So that's going to cause an issue.
That first point as well about white socks. I know Ricky always harps on about it with us and to tell our patients, particularly for those people who can't really feel their feet properly, such as peripheral neuropathy or diabetes. White socks helps you identify if you're bleeding or injured. So I've had quite a lot of my patients who have come in with wounds, and the only reason why they realized it was they saw blood on their socks, which made them look down at their feet. So if you do have an issue with feeling and sensation, white socks is probably definitely the way to go.
Yeah, 100%. That's a really important one because it allows you to see it. Footwear. Again, touched on footwear as well before a little bit, but again, you don't, like I sort of said to you before, there's a lot of evidence now behind a simple shoe from Target, Kmart, stuff like that. A good, just a running or walking shoe can make a huge difference to the risk of ulcerations on the bottom of the foot. So compared to a very flat canvas shoe, say like a Volley or a Vans or something like that, these sort of shoe can really reduce the risk of ulceration. So you again don't need to go out and spend, I put that one up there, which is a really nice shoe that goes max, but they're $250 odd, which is quite expensive. It's a lot of money to go invest in a pair of shoes. Obviously, we recommend investing in a good pair of shoes. It's definitely beneficial. Again, they help you walk, they last longer, you all that sort of bits and pieces. But obviously, $250 is not always accessible to everyone. So making sure that you look for those attributes if you can. Make sure it's supportive. So I think on the next slide we run through some things, so I won't go through it too much. The other one, actually an interesting one, I'll check the inside of your shoes, make sure there's nothing inside there, particularly if you do have any of those neuropathies or any of those issues, because there was a story, I'll say with it. When I was actually at uni, there was a story that went around, which is basically a patient came in with a wound underneath their foot. Anyway, we managed the wound, they debrided it all off, did all the work, cleared it up. They put the patient into what we call a moon boot, set them away. Fine. Came back a week later, wound looked heaps better, it was all clear, it was looking great. Awesome. Sent them back. Great. You pop back on your shoes, you go away now, you don't need to wear the boot anymore. Anyway, a couple of days later, patient came back, the wound was back again. Anyway, did the moon boot again, wound healed up, came back. The next time, someone was smart enough to check the inside of the shoe. What they'd actually done is they'd stepped on a nail. The nail was going through the bottom of the shoe and it was poking inside, rubbing on the foot and causing this wound to break down. That was because the patient couldn't feel it. They didn't know there was a nail inside the shoe that was stabbing their foot. Once they removed the nail, their problem went away. So it's simple things like that. That's where checking it and making sure, using things you can see, visually checking it, feeling inside the shoes can make a big difference. Sizing is another big one. The big one we hear about as well is, I'm an 8, I'm always an 8, I've always worn a size 8. I'm not going to change, I'm an 8. Doesn't work. Every shoe brand is different. So I might be a 11 in one shoe, I might be a 13 in another, I might be all that. It all comes off what shoe last they make the shoes out of. So you can't go off that I'm always going to be an 8, I'll just buy an 8.
Not only that, our foot changes as well. So especially as we start to get older, the foot starts to splay a little bit and your foot actually gets a little bit more wider, which can also increase a little bit of length as well. So as Ricky said, we do sometimes get people who are very firm on this is the size I've always worn and I won't wear anything else. It is really important to get your feet resized and rechecked quite often because things do change over time.
Cool. Another thing to do, this is the inner sole out of a shoe. So that basically just comes out of most shoes, 80% of shoes, I'd say. Actually stand on this. Stand on it and see where your foot sits. It should fairly comfortably just sit inside this. If you're hanging over it, or your toes are going over the end like that, the shoe's not fitting you correctly. You're going to be pushing up. So that's a simple way to test the shoe. You can do it in your shoe shops. Pull out the inner sole of the shoe, stand on it, look at where your toes are sitting. If they're hanging over the side, it's not going to fit you well. Again, you don't need a huge amount of gap around that because this will be slightly smaller than the inside of the shoe. but you want to make sure that you're sort of sitting on there fairly comfortably. That's a big thing to check shoes. We use that a lot to make sure shoes are fitting people correctly. All right, cool. Things to look for in a shoe. So it's mostly the sort of things that we look for. I'll use this shoe. So a stable heel counter. That's this back portion of the shoe. Sorry, I'm on my lights there. Back portion of this shoe here. It should be fairly firm when you press down on that shoe. So you can see that's not squishing. It's not pushing in. That indicates the shoe will stabilize you side to side in the back of it. You're not going to slop out of the shoe and move around. The next thing we look for is good fixation. Obviously, this is like Velcro, but laces, Velcro, anything like that's good. Slip-on shoes tend to lose their elasticity and start to slip off, and they become a falls risk. So we want something that has good adjustability in there. Firm shank. That's actually the bottom of the shoe. So when this shoe bends, it should bend where your toes bend. If the shoe is bending right in the middle, it's possibly too soft for you and it's going to cause an issue. Seamless liners generally are an extra one that you sort of get for generally people who are suffering with blood flow issues or sensation issues. It basically means the shoe doesn't have seams inside it and it doesn't cause irritation. That's a little bit more specific to that one, but they're probably the main things that we look for. Like I said, that toe bend and stuff. But again, in a lot of shoes these days, like this one, you can see they're very firm through the toe. It actually creates that toe rocker. So that's good for people with forefoot pathologies. Moisturising your feet. We spoke about that, but again, there are creams like this. This guy has urea in it. So this has what we call 15% urea. Urea helps break down hard skin and dry skin. 15% is not a massive one. People might use heel balms and stuff like that. They can be 40% urea. They're a bit aggressive for every day, but 15% is just for people who have dry sort of skin. That's a really good one. This is another one we have. It's product in Monaco. I don't know too many things that are made in Monaco, so that's interesting. But yeah, it's a really good product. Yeah, macadamia oil, stuff like that. But these are very fancy creams. This one, interestingly enough, is a mousse. It's got urea in it as well. It dries actually. It doesn't leave a lot of moisture. It's a water based, so it doesn't leave a lot of moisture on it. So a lot of people don't like thick, oily sort of feeling on their feet. This one's really good for us, so we use that a lot. But again, like I sort of said to you before, you don't need to go and spend heaps and heaps of money on moisturizer. Your QV, Cetaphil, those sort of things that you can buy at the shops are great. It's more about repetition. Are you checking?
Yeah, so checking the soles of your feet. So again, as we've touched base on many times, not everyone can simply bring their foot up to themselves and have a look at the bottom of their feet. And we understand that. And that's why a lot of our patients come in for their regular checkups and regular care as well. But we encourage people to check every day. If you can't check yourself, we encourage either get a partner to check for you or someone at home. Or if there's no one at home and you're on your own, using a mirror. So you can get small little mirrors, sometimes from, again, Woolies, Coles, Reject Shop. You can just place it on the floor, put your foot over the mirror just so you're getting that reflection and checking there. Or there are sort of those telescopic poles which have mirrors attached to the end of it, and you can just obviously reach down and have a look through that mirror.
When you put a mirror on the ground, don't stand on it.
Yes.
That's a bad time. Yeah. It's going to create more issues. But again, this one here is a telescopic pole. This is actually an engine examination mirror. So I got it from Repco. You can actually just extend them out. They have a little telescopic pole, gives you a little mirror on the end, and you can check the bottom of your feet. So they're quite a good one. Yeah, like I think it was like $15 from Repco or something like that. So it's another random one. Correct nail cutting. Yeah, so we did talk about this one, the ingrown toenails before. The big thing here is not to cut down the sides, okay? So we want to try and cut your nails straight across. As soon as you start digging down in those sides and cutting down into the edges of the nail, that's when we start creating issues and things like ingrown toenails and other issues. So trying to keep them exposed and out past the tissue is the main thing.
I often hear from patients whenever they're coming for ingrowns, we obviously cut down the side because we need to remove that spicule there. And patients often say, I thought you're not meant to cut down the side. But if there is something down there, we obviously have a better view. We have a better, I guess, instruments, but we got a better view and I guess view of it. So it allows us to actually cut down the side without leaving spicules down there.
Cool. The other thing we wanted to touch base on, as we spoke about, is with the GLAD program earlier, but we actually now have the Canberra Physio Clinic as well as part of our team. So the walking clinic and Canberra Physio Clinic, we have 3 physiotherapists, Toby, Sam, and Ellie, and then an exercise physiologist who's Thea. And so we've actually, it gives us that multidisciplinary approach, which has really added to our care. So we can, patients can move a lot more and means we're getting a lot better care. So we're going to that multidisciplinary focus, which has been amazing for us. And so we've got our physiotherapists at Kingston and Belconnen. They do the GLAD program as well. So if you do have any more questions about that, certainly jump on their website and have a look, and they can help out as well. But that's probably been one of our main focuses and one of the changes, just to make sure that we're providing better care to our community as best as we can. So it's been one of our big things. Takeaways. Your feet basically show the earliest changes, signs of changes. So if you are starting to notice changes in your sensation, or generally occur at your feet. If you start to notice the changes in your blood flow, will generally happen at your feet. So keep an eye on them. They are important to your health and well-being. You use them a lot. They help you get around. They make life a lot easier. Look after them. Check your feet at home. Take care of when cutting your own nails. So that's a big thing. Don't cut down those edges. Manage them straight across. If you're having trouble, seek a podiatrist. That's what we do. I mean, people sort of say, oh, if I just come and have that done. Yes, that's a service we provide. It's no problem. It's part of our job. Obviously, if you are, having concerns with your feet, regular assessments of your feet, blood flow, nerves, innervation, all this stuff is very important. Again, generally seeing a podiatrist yearly. Again, if you are having trouble doing that, the ACT Health does have podiatrists. It is a very busy system, but if you're having issues getting there, you can certainly do that. That's a great thing as well. So seek that. And seek advice if you have changes in your feet.
On that last point about seeking advice, obviously everything that we spoke about today is all quite general advice of everything that we see. So if you do have any specific concerns, you can take some of those points on board, but obviously do seek some attention from a podiatrist.
Yeah, no, and obviously if you do have any questions, we're happy to shoot if you want to.
Yeah, we'll just check if there's any questions from the audience.
Yeah, this is Gabe. I just have a question regarding varicose veins. When we go to a GP with a varicose vein, generally the GP says it's okay, all right, it's just an aesthetic issue, nothing to worry about. Is that really nothing to worry about? Because sometimes the veins are a bit come out, and we wonder whether that would lead to something else.
Yeah, so look, certain varicose veins are that early initial stages of that. So again, if they do progress and become worse, they can certainly lead to that issues that we saw with venous swelling and edema. Again, if you're not getting any, you're getting swelling obviously of the vein, and that's due to that pressure. If you start noticing swelling of your ankles as well, then obviously that's progressing. So compression can certainly assist with that and stopping those veins from distending. So it comes down to, again, like we sort of spoke about earlier as well, the exercises, keeping moving. If you find that you're standing or sitting for long periods of time in the one spot, that's generally going to make those veins distend more and get bigger. Now, again, obviously, if they do stretch and get bigger, they will continue to stretch and get bigger and bigger and bigger over time. So it is certainly one of those things that you can manage sooner than later. Even flight socks, so people wear them on airplanes and things like that. They're a low-grade compression stocking. They reduce DVT. They can be used. You can just buy those over the counter and start using those to help distend it. Particularly if you know that you are sitting or standing for long periods of time, it makes a big difference.
I think touching on that as well, sometimes GPs and ourselves, we do see regular signs just of, I guess, what we can put it down to as typical aging. So it does obviously depend on the severity of the varicose veins. Sometimes what we do see can be, correct me if I'm wrong, but a little bit normal, but it's the progression that we're worried about. And it's trying to get those early interventions, as Ricky just spoke about, such as exercise, compression, working that calf muscle pump, which we like to promote.
Prevention's a lot better than cure, but I mean, obviously, sometimes you got to sometimes give us we see the worst cases, so we see when these things are very, 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 very bad. So sometimes when someone comes to varicose veins, it's like, it's not too bad, it's fine, and but again, certainly intervention earlier is better, and there's some of the things you can certainly do. So if you are finding even you're sitting longer than 30 minutes, try and get up and do some movement. Do some exercises under the table to keep those muscles moving. That will help reduce the pain for sure.
And elevate if you're sitting down for long periods of time. If you're watching telly or a movie, keep those legs elevated.
Yeah, the gold standard there is above your heart. That's a long way up. So there you go.
Okay. Yep. Thank you.
All right.
Sounds like an excuse to put your feet on the table.
You're going to make the most of it.
Excellent. Were there any other questions there? Sounds like we're all good. Well, I'd like to say thank you for this presentation. I've certainly learned a bit about things for my arthritis and some tips that I can pass on to friends. It's been really, really interesting, and I really appreciated all the practical stuff, particularly some low-cost ways to keep your feet healthy.
Yeah.
So thank you really for this presentation. Darcy's just put an evaluation survey link in the chat for everyone, so you can let us know how we're doing, what topics you might want to see in future as well, and of course links to the walk-in clinic. And we'll send out an email next week with as much of the information from tonight as possible so people can follow that up. We've got our last presentation in this series on dental health for Dental Health Month and how that connects with chronic conditions on the 2nd of November. So the link is in the chat and will be in the email with the registration. So just thank you very much to Ricky and Jason for an awesome presentation tonight.
Thank you very
Thank
much.
you.
For having us.
All right, everyone have a great evening.
Thank you.
Yeah.